This morning, we have heard the first historical overview of radiological protection in medicine by Pedro, and followed by two Korean speakers talking about general overview of radiation protection in general, particularly in Korean situations. Now, I'd like to move to another area. It's radiation therapy. Radiation therapy is completely different from the previous talk, actually. One reason is that we give very high dose radiation to the patient. This is the only procedure that is allowed to give such a very high dose to human beings. The reason is very simple. This is to cure the patient. This is our final goal. So even in the unskilled activities, usually the radiation protection of in therapy is not included. This is a different overview, actually. But today, I'd like mainly focusing on the ion beam radiotherapy, which is a very new technology. The reason why I picked up this subject is that whenever we have a new technology, we should have a general way to implement this new technology in clinical practice. And we have to be very cautious about the possible accident and possible side effect and so on and so on. This is a good example to show how it works. So let me first show you the outline of my presentation. First, we show about very brief outline of ion beam radiotherapy. Then we discuss about the key factors for radiological protections. And then we pick up the specific issues about preventing accidental exposure. This is the most important thing for us whenever we have a new technology in radiotherapy. And we summarize by picking up the recommendations of previous guidelines. As you already know, that we have seen a remarkable progress in radiotherapy during the past half century, actually, in terms of increased applicability and improved outcomes. When I graduated from medical school, that was almost 40 years ago, radiation therapy is based on the experience of past experience of each doctors. But now, radiation therapy has a very good tool to make appropriate dose estimation to the tumor and also normal tissues. So it's completely different from the old days radiation treatment. But due to this rapid advance in radiation therapy, we need practical guidance for radiological protection in patients and staff. And we already heard that the publication 86 dealt with the prevention of accidental exposure of radiation therapy, and followed by publication 112, which focuses on new technologies in external radiation therapy. So my talk would be very similar to these two recommendations. But ion beam radiotherapy, which can improve the dose conformation to target volume with better sparing of normal tissues. So we have a better dose distribution to the tumor and less radiation to the normal tissues. But it requires very complex treatment system. And therefore, we need appropriate training and a suitable quality assurance program. And these are summarized in the recently published publication 127. And my talk would be, in principle, the summary of this one, publication 127, but focusing on the practical guidance to the people who is involved in this new technology. Let me first start summarizing what is ion beam radiotherapy. The clinical use of ion beams, such as protons and carbon ions, provides precise dose distribution, as mentioned before, due to their finite range in tissues. I'll explain later, which result in a significant reduction in radiation exposure to uninvolved normal tissues. This is the most important advantage of this new technology. Therefore, the critical advantage of ion beam radiotherapy results from the manner in which protons and carbon ions lose their energy in tissue. And much of this energy is lost near the end of their range in tissue. This peak of energy loss or stopping power is called the Bragg peak. This is not a new idea. It's a very old idea when Dr. Bragg found this phenomenon. This physical phenomenon is exploited in ion beam radiotherapy of cancer to achieve higher absorbed dose within the tumor than in the surrounding healthy tissues. This is the general concept of this new technology. Let me explain what will happen about the physical characteristic of ion beams. Generally, X-rays or gamma rays or neutron beams usually is the highest dose is given at the surface of the body or close to the surface, then decline gradually due to, usually that's an exponential curve. And if the patient has a tumor situated deeply inside the body, there is a problem of this X-rays or gamma rays irradiation because giving a high dose to the tumor, we need a big effects in the surface tissues. Compared with these X-rays and gamma rays, both proton and carbon ion beams have different characteristics. As I said earlier, we have a so-called Bragg peak in certain depth, but this is based on the energy of proton beam or charged particle therapy, carbon ion beams. Therefore, we need exact energy to provide such a beam to treat the tumors. But due to this phenomenon, we have very good target dose to the tumors. This is the basic principle of physical characteristics. Then we have to consider about the biological effect. In the gamma rays and also proton beams, the biological effect is similar and not much changed. But the relative biological effectiveness, so-called RBE values, tend to increase with increment of stopping power. And we call it a linear energy transfer. This is a name, special name, up to a maximum value before declining. So clinically used proton beams are low LET radiation. Therefore, RBE values are very close to that of high energy X-rays. There's not much difference. But for the carbon ion beams, there's a big changes, big difference. For a given biological endpoint, such as a cell killing effect, carbon ion have higher RBE values than protons and increase with the depth and have their maximum near the depth of where the Bragg peak occurs. So in addition to that physical characteristic that carbon ion beam has a higher dose in the deep structure, but also RBE is a maximum near the Bragg peak. This is a combination of physical characteristics and biological effect. Therefore, we need a very sophisticated method to calculate the exact biological dose to the tumor and also surrounding tissues. This is an example of biological effects of many particles and gamma rays and X-rays. On the left side, this is a list of biological effectiveness, RBE in gamma rays, protons, helium, and carbon ion, and neon and silicon argon. These are the heavier particles which can be used for the treatment. But you can see that when the particle size is increased usually, and also neutron has higher RBE values. This is a biological, relative biological effectiveness. On the other hand, in radiation oncology has been struggling with the so-called hypoxic effect of tumors. This was a problem for many years when gamma rays or X-rays had been used for the treatment of cancer. Some of the tumor is very hypoxic situation, then need a larger dose to the tumor to give the same effect This is called oxygen enhancement ratio. Therefore, to give a adequate response to the tumors, usually X-ray needs more dose to the tumor, which is anoxic area. And compared with X-ray, carbon ion has a lower OER ratio, but still not 1. 1 means the exact physical dose can be applied both hypoxic area or usual oxygenated areas. So these are the biological characteristics that we have to consider in the treatment planning. I'd like to a little bit mention about the beam delivery system, how to deliver the ion beams. Of course, we need accelerator part, but I will skip that one. But in general, there are 2 methods to deliver the ion beams to the target tumors. One is a broad beam. When we extract a narrow pencil beam, which is usually coming from the accelerator, it's broadened uniformly in the lateral and depth directions. And part of the expanded uniform beam is clipped to conform to high dose region to the target tumor volume in the patient body. This is the trickiest part of this treatment. But due to such procedures or process, the beam efficiency is quite low, and there is a beam loss at every device used to modulate and shape the beam. Therefore, those points can be production sources of undesirable radiation, such as neutrons. Compared with the broad beam system, recently introduced technique uses a scanning beam, which achieves very highly conformal field of 3-dimensional scanning of a pencil beam. This can be done actually with the recent development of technology to control the beam scanning. We need a very sophisticated system to give adequate dose to the tumors. But since we don't need such an equipment to modulate the dose as broad beam system, the method is characterized by high beam efficiency, almost 100%. Therefore, we can expect a very low production of neutrons. This is the advantage of scanning beam, but we need high technology to control the beam system. So as a summary, an ion beam delivery system generally consists of an accelerator, a transport beam line, and an irradiation system where dose is delivered to the patient with either a narrow beam or a broadened beam. And when ion beam pass through or hit these beam line structures, secondary radiation, including neutrons, are produced, and some of the properties and particles in the structures can become radioactive. This is the problem that we have to solve in this ion beam radiotherapy, and create an so-called autoradioactive component from the beams. So in summarizing characteristics of ion beam radiotherapy, this is a very sophisticated procedure. Therefore, we need a procedure to maintenance of high energy accelerator. This is the beginning. Then we need a high precision beam delivery system is important. And we have to consider about carbon ion, the variable RBE for treatment planning. Treatment planning is essential in this new technologies, actually. And this is a key point, and we need many experts of radiation physics experts. And we have to stabilize the patient, not to move, because in the treatment planning, we target a millimeter resolution of the treatment. It's completely different with the conventional radiotherapy, which you use a very broad beams. Therefore, immobilization of patient and also respiratory gating is essential to avoid possible hazard in surrounding tissues. We also see new problems by this technique. This is activation of equipment, as I said. Air and the patient is also activated slightly. Therefore, we need a protection. And verification of irradiation is another issue, and I'll a little bit tell you later. And during the treatment, the tumor size may be changed. This will cause another problem. At this moment, we don't have any good solution, but probably we need a second or third time treatment planning, even during the process, if the treatment continues 2 or 3 weeks. So first important part is justification. And this is based on the selection of the patient. And of course, this selection is based on the benefits of ion beam radiotherapy, considering the possible harm effects. And the most important target is a locally advanced solid tumor with defined border to remove the lesion without surgery. This is the advantage. We don't need any surgery, but tumor should be demarcated well. And we cannot use this technique for the tumor which easily disseminate in the tissue like glioblastoma. This is not a good candidate. But solid tumor is a good target of this treatment. Carbon ion radiotherapy provides additional advantage for the tumor, which is resistant to conventional photon radiotherapy or chemotherapy due to the increased RBE and also less oxygen enhancement ratio of this treatment system. And the technique is not appropriate for tumors in the wall of digestive tracts, such as stomach or colons, except recurrent colon cancer. This is due to the unexpected movement and possible perforation of the wall. So this is not good for the stomach cancer or colon cancer, primary one. This is not advised for patients with extended metastasis, although we can treat the primary tumors, but we cannot save the patient life. This is an important point. This is a general treatment process. And starting from immobilization, we do a planning CT, and treatment planning is important. And then we do a patient positioning and beam delivery. This process can be repeated every day until we end the studies. But sometimes for the lung cancer in peripheral type, we do only 1-day treatment. So this can be shortened only 1 day. For liver cancer, we do twice treatment. This is very simple. But usually, the technique requires 2 or 3 weeks consecutive treatment, a series of treatment like other conventional radiotherapy. So in the treatment process, careful treatment planning is required for optimization to maximize the efficiency of treatment and minimize the dose to normal tissue. This is a key point. And theoretically, ion beam radiotherapy delivers radiation dose more efficient to the target volume. But nevertheless, the treatment planning must be sufficiently precise to avoid damaging the critical organs or tissues near the target. Here is an example of respiratory gating treatment. In the left side is a no gating treatment. You can see that you need a broad beam, actually, broad range of irradiation due to the moving of motion of the respiratory motion of the tumors. But not only the width of this treatment area, but also you can see that by targeting in certain point of respiratory circle, you can reduce the radiation to the depth structure. This is an additional advantage to do than respiratory gating. So the respiratory gating is now common in all type of radiation therapy. It is very essential, not only ion beam radiotherapy, but conventional or X-ray radiotherapy. It is important. Another thing that we should think is auto-activation by the bombardment of carbon or proton even, create a short-lived radionuclides such as carbon-11. This can be monitored by usual positron emission tomography, diagnostic imaging systems such like this. But then you need a system close to the treatment room? This is a very big question. So in our institution, we have developed the so-called open PET geometry gantry system. In the radiation treatment room, we can put these two-ring open PET system. The advantage of this open PET system is that we can acquire the image between these two rings. This is the trick of this new system. Therefore, there is a possibility that we can monitor the treatment effect just after the treatment, or even during the treatment. This is a new technology, but I will not go in detail. There is a concern about the dose in out of field. This is the most important part. Although we give a very high radiation to the tumors, we should consider out of field radiation. And dosage in the out of field volumes usually arise from the secondary neutrons, photons, particle fragments, and other things. These undesired but unavoidable doses should be considered from the standpoint of radiological protection. And among them, the secondary neutrons are the major contributor. And the pencil beam scanning method can minimize this type of radiation exposure. Therefore, we strongly recommend to use the scanning beam system in your ion beam radiotherapy, either carbon ion or proton beam. This is essential. Another thing that we may have to consider is the medical exposure from imaging. We need an accurate imaging system because to delineate the tumor boundary, it is very important. Therefore, in the first step, we need a diagnostic imaging, using CT, PET, or other nuclear medicine technology. But once we started the treatment procedure, treatment planning CT is very essential. Therefore, anyway, we start this CT. And then treatment rehearsal, we need a radiograph. And in the daily setup verification step, we need, again, radiograph every day. So this process can be repeated every day until the end of the treatment. And then we should have a follow-up CT, PET, or other diagnostic imaging. But considering the effects of treatment dose to the tumors, this is not so large, but easily going up to around 100 milligram. So it's not low dose. Well, it's compared with the treatment dose, it's completely low dose, so we don't have to care about that. But we also should think about this one. And, well, we are close to the end, so we need a management of equipment and air, and we need appropriate management is required for the therapy equipment and also for the air in the treatment room. But the current regulations for occupational exposure in photon radiotherapy are also applicable to ion beam radiotherapy. Several years ago, we have a multi-center trial to measure the real dose in the occupational exposure used by, employed to the ion beam radiotherapy facility in Japan. And we saw the dose is around 5 millisievert for it's estimated in a year, annually. So it's not a serious problem, but we should monitor each individual worker every time. How about the patient and family? Well, as I said, after the treatment with ion beams, the patient will be slightly radioactive for a short time. But again, we estimated the dose, and no specific protection procedure than required. It's far less than 1 millisievert in total. Thus, the method of radiological protection for public exposure in photon radiotherapy facilities are also applicable to these ion beam radiotherapies. So this is a summary of my talk, that the strategy for radiological protection, we have to first optimize the treatment, provide sufficient dose to the target tumor, and minimize the effect in surrounding normal tissues. Safety culture to avoid accidental exposure is essential. And new method and biological effects should be considered. And we need a long-term follow-up of the late effects, and protection personnel is important. And radiation safety management system is we need it. And I quickly go through this part, and of the facilities important, and activation of devices we have to control, and activation of the nuclide is important. And we need a monitoring system for management of radiological protection, and quality assurance in management of radiological protection of facilities. The last topic that I have to discuss is the preventing accident. New technology in radiation therapy brought highly conformal dose distribution, but even subtle errors during the treatment process would easily bring severe consequences. So in order to avoid such accidental exposure, there is a need for prospective, structured, and systematic approach to the identification of system weakness. But this has been discussed in the previous recommendations, so it is not necessary again. But since ion beam radiotherapy requires such a complicated system, we have to consider the new system for preventing accident. I'll skip this conclusion and recommendation because these are already written in publication 127. Thank you very much for your attention.